Hi, welcome to this video on slit lamp examination. Today we are going to discuss a very important case of post-trabeculectomy hyphema. The patient had a shallow anterior chamber. She underwent a routine trabeculectomy with releasable suture. Let's see in the video what we have. So this is the video of the patient showing you post-examination findings. This is the, if you like to know what this is a patient with a narrow angle. So this is a YAG iridotomy which is present over here. This is a conjunctival suture which was present over here. Let's go forward on this. So this is slit lamp. You ask the patient to look down and you check for the bleb. So what we are going to look today, this is the very scary finding which you can get in a patient after trabeculectomy, which you never want to see in your patients with hyphema, but this is something which can happen because patients do get hypotony after trab. Although I have injected air over here, you can see this air bubble. This was in order specifically to solve that issue of preventing that post-op hypotony. But this is a hyphema. But the important thing which you want to see is the iris seems to be curving like this. So this patient had a very shallow anterior chamber post trabeculectomy. Let's see. So going forward, this is the air bubble which I showed you. Now going through, this is the most important part. Do a slit lamp and then check for the depth of the anterior chamber. What you don't want, the reason I have injected air is I do not want to see, this is the slit, this is the internal slit, so it's very shallow. I do not want to see this endothelium touching the surface of the lens because that is going to produce corneal decompensation. So this is the anterior part of this, and specifically air was injected in this patient to prevent that, because at the end of surgery seems to be an issue with formation of anterior chamber, and I had to use multiple sutures, 10-0 sutures to close the conjunctival wound, because the conjunctiva seemed to be thin in this patient. So actually the air bubble is holding that anterior chamber so that the endothelium is not touching the surface of this lens. The problem which you can get with air is that can cause cataract. Now looking at that bleb over here, what you want to see over here, if the bleb is formed, how high is the bleb, the height of the bleb, then how many clock hours the bleb is, and most importantly, does he have any or she have any Siedel is positive, because the anterior chamber is shallow in this patient. So for that, you have to go in and do a test with fluorescein just to show you where the trapdoor is. This is the trapdoor over here. There's a releasable suture going over here. This is the conjunctival suture here. This is the area of subconj hemorrhage. So if you have a very neat dissection, you will tend to see structures beneath your dissection the next day after surgery. So that is sometimes very helpful for you. This is the area of the bleb which you're seeing. So the bleb is not very, height of bleb is not very high. So what I tend to do is I tend to keep that suture, releasable suture, tight and one suture loose. So that will help me to form the anterior chamber. Trying to look at the posterior segment to see for any choroidal detachment. Looking through the air bubble sometimes can be difficult because air tends to magnify that image which you're seeing at the back of the eye. So that sometimes can be challenging, but if you can go through this area, usually it's pretty simple in that. So this patient did not have any choroidal detachment. So the important test we're going to do is the Siedel test. So put local anesthetic. I'm putting fluorescein dye. I'm just use a sterile strip, fluorescein strip over that area, and try to blink, ask the patient to blink, and then you will see if that tends to get diluted or not. So this patient did have mild Siedel positive test. So the other way is to gently push the eyeball, so that will, if there is any potential leak, that will show up. So if you see very closely in this patient, you will see that this dye, there's a sort of stream of fluid that flows down. So you go on to higher magnification. on fluorescein. Usually sometimes it's difficult to capture on the camera, but you will be able to see this. This is the area. Keep looking for this area. So if I gently press on the eyeball, you will see, even if you do that, you can see this area. Even without fluorescein, you will see blue light, cobalt blue light. You can see or appreciate that area of leakage from the bleb. So this patient had a mild Siedel positive test with hyphema, flat anterior chambers. So this is something which you do not want to see in your patients with glaucoma. So you're stuck. What do you do with this patient? Because the patient is complaining, I was seeing pretty well yesterday, I'm not seeing anything. So number one, I always counsel my patients that it'll take about a month for you or revision to recover after glaucoma surgery, because it tends to go down and then come back because you deflate the eye, and it takes some time for the eye to come back into shape before it sort of reforms into that area. What to do in this patient? So you've got a mild Siedel positive, so I ask the patient to patch the eye for 24 hours because not very profuse type of Siedel positive test. The second thing which I asked the patient, or which we planned to do, was if that air got absorbed, we'll go in and we'll put SF6 gas, so in order to form that chamber. So that's exactly what we did. So we did a patching, the Siedel got negative, but the anterior chamber still remained shallow, and it was actually flat on the second or the third day. And I went in because I had an initial needle track during the surgery. I injected 20% SF6 gas, and the patient was doing very well afterwards, and the anterior chambers was formed, because the number one key thing is to get that eye to be formed back into shape. That is the most important thing after trabeculectomy. If you can achieve that, then you will get your goals achieved. The problem or complications which we are encountering in this patient was, because of the shallow anterior chamber, she did develop posterior synecdoche formation, but for that I added atropine drops, and obviously the peripheral iridectomy is working, so we are safe in that part. So this is how you will manage a tricky patient with trabeculectomy. Thank you very much for watching. I hope it's been useful.